Not the end of the road. Thank you, Dr. Azad, for giving me this topic. Not the end of the road. Rehab, resources, and recent advances. A lot of it has been covered already by Sir and by Anand. And when we say not the end of the road, certainly not, because with the betterment of neonatal facilities, increased survival of small neonates, situation today stands at betterment of treatment facilities, more in-depth know-how, better awareness from a multitude of committed ROP specialists, spreading awareness throughout the country, and early screening referral from pediatricians from awareness to them, timely aggressive treatment and early rehab to improve the global development of the child and minimize disability. At this point of time, I would like to appreciate our icon, Dr. Rajvardhan Azad, for taking it in the last 30 years from a point where it was a small, minuscule project to somewhere where it is now, where the number of ROP specialists grew from a small number of 3 and 4 right up to 233 as it lies today. This was joined in by Professor Mangadogra and later by Subhadra and Anand to bring it to the status that it has come today, because today it is a worldwide problem. Just seeing the numbers in this audience tells us how it has grown exponentially and how we are able to communicate with everybody, because this awareness program also, which was brought forth by Dr. Professor Azad, has also helped the inmates of the IROP society and the people who are practicing ROP to sort of spread awareness in their localities so that it becomes a multi-center project. Now, there is not much time, but I would like to say that this rehab is something which is very important, because there is a rapid assessment of avoidable blindness, which is a population-based survey that drives to prevent avoidable vision loss through collection and interpretation of high-quality data, because the numbers that become blind every year is massive. That is 500,000, one every minute. And the mortality also is the same. Now, when we talk of rehabilitation, we have to rehabilitate because higher number of children are sort of surviving this now, and the neonatal care, though it has improved, in certain areas it is compromised. There's lack of screening and treatment because the burden is high and the numbers that really do it are less. So here comes the situation where we have to have other trained personnel who go in to these outreach areas, and they photograph by the telescreening techniques which Dr. Anand Vinekar has built, and they train these people in their own setups, and he is now increasing the number of these programs not only in Karnataka, but he's also doing it all over India, which I think that is his current baby just now. And it is not the end of the road, because the thing is that there is a lot to be done in this. But what we find in these children who have ROP, they have a great association with neurodevelopmental disorders. And these neurodevelopmental disorders run up to almost 68.4% in these children. And that is the reason why we have to address them, whether they have mild delays or moderate delays or severe delays. And these have to be addressed not later, but as the child is in the NICU, because you have to know that at that point, if you target it, you're going to sort of prevent a lot of problems for the child and give him normalcy to continue. So the Ministry of Health and Government Welfare, Government of India Resources, that is the RBSK, they have formulated guidelines, and they have these district level centers which cater to identification and management of 4Ds, that is defects at birth, deficiencies, diseases and developmental delays and disabilities. The initial step of deputing trained and dedicated mobile health teams for screening and children up to 18 years of age selected health conditions under the RBSK. And this is very important. Now, when we talk about resources, the resources, there were two Indian-based studies which showed that there was like screening cost was about 253, and per infant it came to 6,500 vis-a-vis 1169. And as Dr. Azad also has shown you, that it is 2,000 rupees worth several dollars in the West. So the thing is that our costs are low, our numbers are high, but we have to make a bigger effort at trying to control this, because this is a major project and this is something which we are really going to help the little neonates in. Now, these resources also sometimes come from the major trusts, that is the Sight Savers Group or the Diamond Jubilee Trust, or there is a Japanese trust which is also there. And these people are ready to fund, provided they know that the person who is taking on the onus of taking that funding or the machines, that is the tele-screening machines, have to do justice to it. So they have to be convinced before they kind of sort of agree to it. Now, in the recent advances, visual impairment at a young age has lifelong consequences. So the advances have to be not only addressed in the form of what kind of advances are there in the technical part or in the disease per se, but also in the visual rehab. Now, the RBSK has a center which has a holistic approach to children, and this is age appropriate level because they cater to less than 18 years, but the more emphasis on children who are less than 6 years, where they have areas which have domain specific equipment, trained personnel, and other specialty people like dentists, optometrists, audiologists, psychologists, physiotherapists, vision therapists, and such a center would act as an apex center of the disease. And their goals are simple. They have to target these children and do good to them by diagnosis, intervention, referral, and prevention of psychosocial and also psychosocial interactions. So this is how they get all their children. This is the major kind of a thing where they then, the referral is there and they review, and then the follow-up is there. And these are general guidelines of how they manage this kind of thing, because it is a very labeled kind of format which goes through the clinical examination of these children, and the help that each one requires is tailor-made to them. And this is at the District Early Intervention Center, and this is caters to community early intervention. So they target general examination, gross, motor gross fine reflexes, speech language communication, receptive language, expressive language, associated abnormalities, cognition, social emotion, and play. And so in short, this is what the DEIC does. And they target sensory integration, which controls all our 5 senses, along with the tactile body position, sensory integration, and the balance activities for the child. So it is an interdisciplinary approach and a transdisciplinary approach, not a multidisciplinary approach, because multidisciplinary caters one-to-one, whereas this has to be an integrated activity of all the groups put together. So these are just a few examples of how they do it. And they say that this is not a drug or a vaccine, it's not a device, it's a group of therapists working together, solving problems and enhancing capabilities. Now, the early rehab, as I said, starts in the NICU. Now, newer predictors, apart from the gestational and birth age, they have had certain neonatal scoring systems, but they have not been of much value. But the important thing is that low weight gain, less than 32 weeks, if it is not less than 50%, this is a high predictor for severe ROP. The WinROP also addresses it, that the level IGF-1, if it is less, it is this. Now, just to run over a few things, the telescreening, a lot has been said of it, and we know a lot of it from the KidROP model and the other models, like the one which is there with Dr. Ale Banka, the Rotarop, and the one which is at with Sucheta. There are more centers that the Aramb is starting. These people have taken it to a different level altogether. Then newer therapies like propranolol, then that is also supposed to have good effects, and the IGF level ones, which is kind of, they are treating with concentrations of IGF-1 and IGF-BP3 because it's found to be effective. and the parenteral nutrition, which is also very important in these little children, because if they are not
Dr.
undergone
Karobi?
good nutrition, just few more slides, sir, 2 to 3 more. The omega-3 fatty acids, the E-lipids, the gene therapy also has been spoken about, and uh, the visual rehabilitation, of course, deals with the primary senses of the children, and they target the survival reflex, the sucking, rooting, and snout reflexes. And last but not the least is the artificial intelligence, which can demonstrate intra and subjectivity, and it has a kind of specificity and sensitivity of almost 90 to 95%, and it improves the efficiency, accuracy, and objectivity diagnosis, and facilitates quantitative disease monitoring and risk reduction. That's all that I have to say. Thank you so
Thank you,
much.
Macha.